burns. Briefly, you do not have burns, and they actually used to give burns in the last semester in 232. They've actually moved it out of there and they put it into this because ATI has some content on burns. So we want you to be prepared for ATI testing, so we're going to go over burns. So now you will have had all that you need to know for ATI testing after next week's lecture, of course. So burns. And next week is endocrine and hematology, a lot of which, especially with endocrine, you've already gotten in 132. So a lot of it will be kind of review, like diabetes and some of the things that we're going to talk about. Okay, so burns are among the top 5 leading causes of injury and death in young children. Males have a higher risk of being burned than females. They do find that males have more gross motor abilities at younger ages and exploration of the environment. 10 to 25% of all burn injuries under the age of 3 are the results of child abuse, unfortunately. Again, you want to match the injury with the age of the child. A great example, here's a picture of a child that came into an ER. This was a case study, and this was a 2-year-old that the mom said went into a bathtub. Okay, a hot bathtub, and that's how she got burned. Now, when you think about going into a bathtub, everybody's shaking their head, right? When you think about going into a bathtub, right? How do you go in?
1 foot.
We are 1 foot at a
That's
time.
right.
You don't jump in.
You don't jump in. And even children very rarely are jumping in. You're going to step in, even if they're climbing, right? They're still going to put one first.
Pretty advanced 2-year-old to turn the water on too
And if
fill
they
the tub up.
put the, well, she didn't, I mean, again, this was off the internet, but I think the statement was that, she had put the water on and was running hot water, whatever. The child went to go in the water and burned herself. Now, again, burns that severe, first of all, you have to be submerged and both feet. So that means the child literally stood at the same time in there. Usually you put a foot in, right? A toe in or something.
Stay there. You try to get back out.
Right. You'd put a foot or a toe in, and when they felt it was hot, they would go out. And they might burn their foot or their top of their toe, but they wouldn't both legs and that much. So again, when we talk about things that don't match, puts a bell off in your head, contact the police, contact IFAS, right? So again, especially in young children. Another thing I had seen in children's specialized, actually, a 7-year-old boy with autism had gone to grab something off the stove and had, poured it on himself and burned himself. And we had one this semester too of a young girl, I want to say, help me out here, 3, 4, how old was she? Who had been cooking something, maybe 6, cooking something at home, And again, not necessarily abuse, but neglect, certainly, because the 6-year-old, should they really be working the oven and cooking,
The 6-year-old was actually doing the cooking?
Yeah, and and she burned herself.
My brothers didn't cook till 20.
Yeah, my family.
6-year-old
That
cook.
seems to be the problem too, Bill, if anything, yes.
That's
It's
another
people
issue.
not cooking really not great. So again, that wouldn't necessarily be physical abuse, but it would definitely be, would want to look at those kind of things for neglect, children not being developmentally able to do something and doing it. 4 major types. Thermal, which is the most common. That's what we think of when we say grabbing something off a stove, going into hot water. Then there is chemical, which is like bleach, if somebody should come in contact with that in their eyes, and they inhale it, drink it even. Electrical, contact with electric wires. Remember, when there's an electrical, there's always an entry part, and there's usually, there usually is an exit port. So you got to look for them, meaning that, if somebody grabbed an electrical wire with their hand, did it come out the shoulder? Is there going to be injury to the shoulder too? Because electricity finds a way in and out. Radioactive, meaning sunlight or radiation therapy. People with cancer, obviously when they're getting radiation over a period of time can develop burns that way. So those are the 4 most common types of burns. What happens when there is a burn? Well, the first and initial response is like that shock response of a vasoconstriction. So it's that fight or flight, epinephrine, the norepinephrine, those vasoactive hormones we talk about. Also causes fluid shifts. It makes the body start to retain fluids, so blood pressure will go up. So that angiotensin aldosterone, but also vasoconstriction occurs. Increased capillary permeability and fluid shifts from the cell into cells from the vessels. So the body's protection is to move from the vessels, it goes into the cells. So you actually see a very large edema occur, like overall edema of the body can occur. Metabolic needs increase, and the need for caloric intake actually increases too. So initially, when there's a burn, there actually is a hyperthermia, but then the person can actually have hypothermia because of the skin, which is your natural first line of protection. So obviously infection is high, but also is your first line for keeping the body warm and heat, can actually over time cause a hypothermia. There's a lot of body surface area that's affected. how we look at burns is it a partial thickness? That means is only part, you have 7 layers of your skin, or only part of those layers gone, then it's a first or second degree. If it's full thickness, 3rd degree, it goes through all layers of the skin. Okay, permanent tissue injury. So again, you want to look at the thickness of it and the depth of it, but also the percentage of the body involved. So how thick is that burn? Is it a first or second degree, meaning only part of the skin, or all of it, 3rd degree? And how much of the body surface area is affected?
Is it fourth degree?
Hmm?
Is it fourth degree or the third degree is the highest?
3rd is the highest. 3rd degree,
Which one that include muscles also, right?
that's the 3rd degree. That's right. 3rd degree is the full thickness burn. That means it goes all the way down to the muscle layer and includes the muscle. That's right.
And it shows the bones.
That's right. That's absolutely right. That's 3rd degree. Once you get into the muscle or the bone or anything deeper than the first layer of the skin, you're 3rd degree. When you go through all those layers of the skin. 1st degree basically means you have skin present and it's just really red.
That's not
Most
burn.
exactly, like a sunburn is a 1st degree burn. Most of us in this room have had 1st degree burns. You touch a grill real quick or something, you're gonna get that redness, that's a 1st degree burn. A sunburn is a 1st degree burn. A 2nd degree burn means you have some layers of skin. You start to blistering, there you go. See? You hit something, right, when you're pulling something out of the oven. Yes, I've done that many times, especially me. So these are the kind of things, blistering, when you start to have blistering all, you're getting into 2nd degree burns. Okay, when you start to blister, because then you're getting into more of the layers, and that's why the body sends fluids to that area. And you get the edema and you get the blister, okay? Full thickness, though, goes into the muscle, goes into the bone. Yes. Usually what happens with 3rd degree is you have sections of 3rd degree, which are all the way down through, and then you'll have sections of 2nd. So you will see blisters also, but you will see areas, does that make sense? So like you see, somebody with a 3rd degree burn probably a 2nd and 1st degree in other areas too.
Yeah, surrounding the 3rd degree.
Correct, so surrounding the 3rd degree burn. So you will have blisters, but they're more the 2nd degree. Does that make sense? Because you have all combined when you have it that bad. And then, okay, so that's degree. But now, once you get to degree, you still need to know how much of the body is affected. Because I could have a 3rd degree burn that's this big, okay? Versus a 3rd degree burn over how much of my body. That's right. And how much, not only how much of my body, but where in my body. If it's my face, my head, my neck, my chest, that's obviously going to have a higher percentage than, let's say, my hands. Okay, so again, when we look at body surface area chart, they go by the palm method, and it's the palm of the patient. Okay, so if you have a pediatric patient, the size of their palm against their body is how much, they actually look at percentage of burns. Does that make sense to you? So that child's palm is going to be much smaller. Like you wouldn't just take your own palm and say, okay, 1%. So for example, if they have burns all up and down their arm, you would take their own hand size, obviously, approximate, and you would be seeing how much of a percentage, and it would give you maybe 5%, 10% that's covered. They have 10% burns on their left arm that are 3rd degree in nature. That's how it's kind of like documented. You see what I'm saying? And again, they have burn specialists that come in and do this. St. Barnabas Hospital, very big regional burn center, obviously right in our area that a lot of these patients go to. We used to spend clinical days there when I was in school. So, and again, some areas actually get higher percentages just from the very fact of where they're located. For example, the chest and the face have higher percentages, and it kind of gives you that too. So do I expect you to be able to do that, obviously for exam? No, but you should know how they do it. What the difference between 1st, 2nd, 3rd degree is, and what the palm method means. Okay, and then your interventions. Immediately you want to remember your ABCs, airway, breathing, circulation, right? They're going to actually have a fluid loss of the intravascular space. So you want to give them lots of fluids, and the fluids you want to give them are the isotonic type. So you want to give them things like lactated ringers and normal saline, okay? So people say to me, well, I don't get it. You just told me that they're going to be retaining fluids. So why am I pouring fluids into them? Because they're retaining fluids in the cellular space, not the vascular space. Does that make sense? So all of their shifting is occurring because they're losing, because of the burn and because of the heat, it's going to draw the fluids from the intravascular space into their cells, which is going to cause them to become edematous, but is going to put them into hypovolemic shock. because they have less blood circulating volume. Does that make sense? Therefore, they need fluids. You want to prevent infection, which again is one of the later thoughts, and control their pain. Watch for hypovolemic shock, as I mentioned, because again, pulling fluids out. And then a lot of times they look at things like the Parkland and Galveston formulas, which are like much higher rates of fluid resuscitation, more fluid that they're actually giving them. Remember we talk about like how you're going to replace fluids. In these cases, a lot of times they're replacing like 5 times what they normally would get. But we don't have to worry about that for purposes of this course unless you're going to become a burn specialist nurse someday. Just know that they have those formulas out there. And again, controlling for hyperthermia initially, but that over time, once that initial injury, the first few hours, it's going to be hyperthermia. But then over time, a hypothermia can occur because of all the loss of the skin mass that's occurring from all these burns. So again, over time for wound management, they're going to remove necrotic tissue and debride wounds quite frequently. They're going to maintain moist wound conditions and adequate circulation, conserve body heat and fluids, protect from infection, and over time you want to prevent the scarring and contractures. So they're going to use things like Jopes stockings, which to help to prevent that. And this is just a patient that has some Silvadene ointment. And as you can see, there's actually some good healthy tissue. Probably can't see because the light is on, but I'll turn it down. There is some healthy pink tissue that you can see around the edges. And then you have the necrotic kind of dead-end tissue that they literally go in after they sedate the patient. They will go in into like a tub bath, really warm, hot room, like a sauna. And they'll bring the patient in there with whirlpool water and they'll take a scrub brush and scrub those down. All that dead tissue. And they do sedate, yeah. Yeah. But it is painful, extremely painful. And that's again to prevent infection and to promote the positive wound growth. And then obviously they're going to do things like skin grafting from other areas. So again, antimicrobial agents like Silvadene, sulfamylon, bacitracin are going to, hydrotherapy as I mentioned, allograft and even autografting, meaning they take cadaver grafts, and also from other parts of the person's own body, like thighs, inner thighs, if they weren't affected, they can graft from there.
Years ago, my father was actually in a car accident, and he had burn on his shoulder and like head, and they actually took it from his thigh.
Yeah,
And
it's very common.
he was in Valhalla, Westchester Medical Center, Valhalla, like a month, and burning your neck.
Yeah.
And then they do that.
And he was fine?
Yeah, you could still see it, and he had to wear like compression
Jopes stockings,
over
yeah,
it
exactly.
to keep it.
Yeah, that actually helps to keep it from scarring as much and contracturing if it's down to the muscle layer, because the muscles can
Yeah,
contracture very well.
you could still see like where it was. It didn't
Yes.
completely discard it completely go away.
Usually with third-degree burns, it's very hard to make it completely go away, obviously, but they do try to at least put a protective layer. That's why they graft and try to make it so that their skin that's healthy and protective there. That's right. So what Ina is saying is that when they autograft, they're taking it from your own body, like what Melissa mentioned, what I was saying, like inner thigh usually or another area. Allograft is either cadaver, sometimes it's bovine, sometimes it's foreskin. They've actually used foreskin that they've grafted and made into skin. It grow larger, and then they graft that. So it means other than your own, like another, usually not an issue with immunosuppressive drugs too. People have asked that in the past, like, well, is it like transplanting no, it's not like transplanting an organ. Even though the skin is an organ of your body, your body usually does not reject it. Although it could not take. What they do is they actually scrub down the skin underneath to get the blood vessels, and then they put a very thin layer of that so that it hopefully adheres, keeping it very moist. Management of a minor burn. Okay, so now you're at home and, like Stephanie here, to use you as an example, gets a burn. Okay, 1st degree, even a 2nd degree where you're blistering, what do? Initially, you don't want to put ice on it. Many people think, oh, ice, what about butter or toothpaste? And I've heard all different kinds of, right, stories. The best thing to do is get it under running water. Cool water. Cold water, but not ice. Because ice will actually freeze and can actually harm the tissue. Can actually cause like a, exactly, I was going to say frostbite, like a frostbite. It actually can harm the tissue. So you want to put under cool running water. Removing any jewelry. So for example, if it's your hand and you have a ring there, you obviously could have swelling, localized swelling to the area. So you want to remove any jewelry you might have in that area. clothing, topical antibiotics and dressings while it's healing, usually it does scar over time, and monitoring for localized infection. Obviously, the areas are covering it up. Silvadene, bacitracin ointment, something to kind of keep it covered.